This is Dr. Jean Johnson, the founding dean and professor of the School of Nursing at the George Washington University, and will be presenting the theory burst on quality improvement. The objectives for this session include that you'll be able to define quality improvement and integrate key messages into your curriculum, to describe the factors that have influenced the development of quality improvement, also to describe the framework and process for quality improvement processes, and probably, again, most importantly, describe at least 4 different teaching strategies to integrate the quality improvement content into your curriculum. The QSEN definition of quality improvement is the use of data to monitor the outcomes of care processes and use of improvement methods to design and test changes to continuously improve the quality and safety of healthcare systems. The key message in this theory burst is that improving patient care requires a systematic process of defining problems in order to identify the potential causes and then develop the strategies to improve care, as well as continually evaluating and monitoring those improvements. This process requires the ability to measure care. It's important to note that we can only improve care if we measure how well we're doing and compare our performance against others, and therefore benchmark our performance against others. So why should we be concerned about quality of care in this country? Doesn't the U.S. have the very best health care system in the world? Well, fairly recent data suggests that this really is not true. And we have known for several decades that there is an unacceptable number of deaths and harms due to medical error. Based on a report from the Office of the Inspector General looking at Medicare data, this report found that 1 out of every 7 hospital patients with Medicare experienced an adverse event, and this was in 2008. This number ended up being around 134,000 Medicare recipients a month. So if you multiply that by 12 months, you know that we have a totally unacceptable number of harms of just Medicare patients. And at least 44% of the mistakes were preventable. Translating this into dollars, this cost the federal government around $324 million a month. Another study done by Health Grades looking at data from Colorado found that at least 1 million patient safety incidents occurred in Medicare patients from 2006 to 2008, costing almost $9 billion. And not only were there 1 million patient safety incidents, but 1 in 10 patients who experienced a patient safety incident ended up dying. This is just an unacceptable number. And then again, more data from North Carolina that there were 25.1 harms per 100 admissions, and 63% of those harms were preventable. There are new estimates of the deaths associated every year with medical error, and the new estimate is much higher than the initial Institute of Medicine estimate of around 100,000 deaths a year. And the number recently estimated is between 220,000 to 410,000 deaths a year. Now, there's discussion and disagreement about the use of different methods in assessing the number of deaths per year due to medical error. However, even with the lowest estimate, which is still 100,000, that is unacceptable in the world's most advanced healthcare system, or any healthcare system for that fact. I want to focus in a little bit more on the Colorado study that I had mentioned in the previous slide, because here we can focus on the most common patient safety incidents, and this is a rate per 1,000 patients. The most common patient safety incident was failure to rescue. The second most common was decubitus ulcer, followed by postoperative respiratory failure and then postoperative sepsis. Every single one of these common incidents is related to nursing care, and particularly the failure to rescue and the decubitus ulcer. And those are the two most prominent safety incidents. So nursing has a lot to be concerned about in terms of improving quality of care. There have been a number of breakthroughs in quality improvement, and I am so proud that Florence Nightingale, certainly the mother of nursing, of modern nursing, was one of the leaders in quality improvement. And her work during the Crimean War, where she really documented numbers of infections and recognized how important it was to keep wounds clean and the environment clean and whatnot, was probably the first to really use quality improvement methods and creating the use of a pie chart to apply to monitoring data. You then fast forward more than 100 years, and we move to Avitas Donabedian in 1966, who wrote one of the most important and impactful reports about quality of care. And he is the person who really established a way of looking at and considering quality of care. And he defined structure, process, and outcome as three important elements that were linked, that you had to have the right structure to create the right processes to get to the right outcome of care. And that structure has been used for decades now as a way of framing quality improvement. Moving to 1999 with the Institute of Medicine report, To Err is Human, really began to set the stage and bring public attention to the issues of medical errors. This was followed by Crossing the Quality Chasm and a number of other reports since that time around quality and improving healthcare. Then in 1991, Don Berwick, who is a pediatrician and had been the director of the Centers for Medicare and Medicaid, initiated an effort, the Institute for Healthcare Improvement. And the Institute for Healthcare Improvement has had a very wide impact on healthcare institutions and have really helped people to create quality cultures. And then in 2010, much more recently, as a national policy, the value-based purchasing has been promoted so that providers and institutions do not get paid for providing poor care. And there are areas and events that have to be reported, serious reportable events, that are then not reimbursed by CMS. And that's a really major change, because there will be more and more outcomes that are looked at that, as they negatively impact patients, that healthcare institutions will not be paid. There's also a national policy around quality improvement, and there are three major goals related to this national policy. One of them is better health for populations, really looking at population care, getting good epidemiologic data, figuring out what kind of interventions can keep people healthy, and what kinds of interventions will help better monitor disease processes and lead to better treatment and more effective treatment. Then the second goal is better care for individuals, that we still need to look at, how we take care of each individual patient. What are their needs? How can we best address those needs? And then lower per capita costs. This is definitely a national agenda item because it's clear that healthcare costs cannot continue to increase in the way that they have in the past decades. I want to go over the quality improvement process, which everyone is likely familiar with in terms of just even considering it as analogous to the scientific method. But where we begin is certainly identifying areas that we want to measure, and we monitor those areas using specific measures, and then creating benchmarks. Where do we want to be with those measures? For instance, in terms of pressure sores, where currently are we? Any institution, do 3% of our patients on a particular unit have a pressure sore, or 0% of patients? If we're at 3%, where do we want to get? 0%. So monitoring is very, very key to identifying a problem. If there is a problem identified, which suggests that there is a measure that is outside of where we want to be as an institution, then we have to really figure out, okay, so what's causing this problem? And once we figure out some probable causes of a problem, then we really need to figure out a plan. And this is where the Plan, Do, Study, Act, or otherwise known as the PDSA, is done. And that's where an intervention comes in. And then this is a cycle. We continue to monitor those measures and make sure that our interventions have worked. If the interventions don't work, we go back and look at that and figure out what else we might need to do. This slide presents a summary of the Institute of Medicine aims around safe, efficient, equitable, timely, effective, patient-centered care, linked to a framework of measurement, which is really the framework that Avidis Donabedian had laid out. So that any one of the IO aims, for instance, if we take safety, can be considered within the structure, process, outcome framework. So that if we were looking at safety, and we might look under structure, look at the nurse to patient ratio. Are there enough nurses to patients to safely take care of patients? Is the equipment that we're using safe? If we look at process and safety, we can look at, for instance, medication administration, or what is the procedure that might be used for wound care around safety and process. And then if we're looking at safety through the lens of outcome, is there an adverse event that happened to a patient? And if so, what is that adverse event? So you can take any one of the IOM aims and use the framework of measurement of structure, process, outcome to identify specific measures that will help us understand the quality of care that we're providing. There are specific nursing sensitive measures, and these are measures that have been defined in a way that recognizes that nursing has a broad input into the measure, and whether the quality of care that's provided related to that measure, is related to good nursing care or not so good nursing care. Now, some of the nursing sensitive measures that exist is the National Database for Nursing Quality Indicators that had been developed by the American Nurses Association and is now integrated as a product into the Press Ganey's patient experience and other databases. This is actually really an exciting step to integrate nursing measures into a national product. There's also the National Quality Forum that had nursing sensitive measures, but they've also integrated these measures. There had been initially 15 measures that were winnowed down to 12, and they were specifically labeled nursing sensitive measures, but they're now integrated into the broad measurement set that the National Quality Forum recognizes. In addition, there's the Hospital Consumer Assessment of Healthcare Providers and Systems, otherwise known as HCAHPS, that basically is an assessment of patient experiences and includes specific questions related to nursing. Now, this particular database and measures is important because it's really the only fully national database that has specific questions around nursing care. And it's different from, for instance, the NDNQI in that specific hospitals agree to participate in the NDNQI, and they provide data and get benchmarking information back. But the HCAHPS is required for all hospitals to use and to collect data. In addition, there's the Collaborative Alliance for Nursing Outcomes that had been related to some of the work that the ANA had done in terms of the National Database for Nursing Quality Indicators. And the Collaborative Alliance, otherwise known as CalNOC, has maintained their distinct database, and particularly for facilities in California, but they also have hospitals beyond California. And then one of the very promising events that have happened is that there's been significant progress with the Centers for Medicare and Medicaid to integrate nurse staffing and skill mix measures along with falls and falls with injury measures into the Hospital Compare website and information. This is really critical because the Hospital Compare is the public site that people can go to find out information about hospitals. And since it still is one of the only reasons for people to be in the hospitals is to get nursing care, having information about nursing is really vital to the public. There are several criteria that need to be met for measures to be useful. One of them is that they have to be important to consumers or for internal quality improvement. And, measures are really used in two ways. One is to inform consumers, and the other is for internal quality improvement. So if a measure is related to either one of those, then it's important. Measures have to be accurate in terms of their reliability and validity and risk adjusted. And there's got to be large enough numbers of events that the accuracy is ensured. A measure has to be influenced by the provision of high quality of care or low quality of care, that there's got to be some variation. If you have a measure and 100% of providers or facilities, provide the care specified in the measure, then it's really not of much use, because what you're trying to do is differentiate, those entities that are providing really good care and those that aren't and need to work on it. And then the data has to be collectible. That's another very important criteria for measures. So the use of measures, I had noted in the previous slide, one of the major uses is for the internal improvement of care and the external reporting. But I wanted to really focus on some of the information that is available to the public in terms of external reporting. And one of them is the Hospital Compare that I had noted includes the HCAHPS data around nursing. But there's also Nursing Home Compare that presents to the public a number of measures of nursing homes so that they can take a look at the nursing homes that do particularly well. The Nursing Home Compare uses a star rating in terms of identifying, the really, really good nursing homes get 3 stars. The not so good nursing homes get 1 star or no stars. And that helps consumers understand the data a little bit better. In addition, there is the Home Care Compare, and there are health plan measures that can be useful. And these are HEDIS measures, and again, available for public reporting and also for accreditation of health systems. Then there are also recognition programs that use data and report data, such as the Diabetes Care Recognition Program that's offered by the National Committee for Quality Assurance, and other entities have recognition programs and provide data about specific either providers or institutions. So public reporting is a very important mechanism that the federal government considers useful in driving people and their decisions to higher quality healthcare providers and institutions. In the previous slides, we've talked about measures and monitoring as well as measure reporting. Now, talking about problem identification that comes from the monitoring, wanted to point out that certainly a major source of identifying problems is through the measurement process, but it's also possible to identify problems outside the usual monitoring process. Nurses frequently see things that may need to be addressed in terms of keeping patients safe and improving outcomes. But turning to the ongoing measurement process to detect variation, because I had mentioned the importance of selecting measures where there is variation, that we can use a variety of tools, including histograms, control charts, run charts, Pareto charts, scatter diagrams. There's a whole list of tools that can be used to help organize information and create dashboards around how well units are doing. This slide shows the use of a control chart and data that represents the nurse-to-patient ratios. In a control chart, there is both an upper and lower control limit. And in this particular case, anything that's going above the upper control limit is a problem. It's out of the benchmark range of normal. And in this particular control chart, in terms of looking at the frequency and, how the peaks are spread out over this chart, what it's telling us is that there are fewer nurses to patients on weekends. And this could be an issue and could lead to a patient safety problem. This slide shows another tool that can be used to monitor and identify problems, and that's a histogram, where in this particular chart, the medication errors for each day is presented. And you can see that on one day, there are as many 8 errors, and on another day, there's as few as 3 errors, although we would like to see 0 errors in the medication administration process. By looking at this histogram, you can then go back and look at factors that might have come into play on the days that there are more errors. And then you can take that information and figure out what are the potential causes. So once a problem has been identified, we turn to looking at the causes of the problem. One way to do that is through a root cause analysis, which is a systematic approach to get to the true cause of the problem. And there are several ways to do this. There is one that approaches it by asking the 5 whys. So why do we have medication administration error? And one possible explanation could be, well, there was a shortage of nurses on the floor and the medication nurse kept being interrupted. Then the next why is, well, why was the medication nurse consistently interrupted? And you can kind of keep going through the 5 whys. And by the time you get to the 5th one, you're pretty deep into the process of understanding what might be the cause of the problem. Another way is simply doing brainstorming, sitting with some colleagues and going, so what do you think is going on here? And it could be that the person passing out the medications is a new nurse, and perhaps they weren't as familiar with the system as some of the other nurses were. So their brainstorming is really a very good way of identifying root causes of problems. And then you can also do a fishbone diagram that looks at the cause and effect of a problem. This slide shows a diagram of a fishbone, cause and effect. And in the fishbone diagrams, there are general categories of areas to explore. In this one, I've included ones that are generally common to explore: people, processes, equipment, regulation, management, and environment. You can select 2 of those, for instance, if you think that there are only 2 really relevant areas to explore, or you can change them. You can add whatever category of cause you think might be related. And again, the issue here is getting down to the root cause. If you were looking at people and a medication error rate, perhaps it is that the person giving the medication was not experienced in the system that was being used. And, there could be another error kind of explaining that, this person was new, came from a different institution that used a different system, and that there wasn't the in-service that was developed or the test back. And so you can really outline the cause and effect on this fishbone diagram of the problems that you're trying to identify the causes of. As the next part of the process of quality improvement comes a small test of change. Once we've monitored, identified a problem, and identified reasons for the problem, we then move into developing our plan, which includes what are our objectives, what do we predict will happen, what data will we need to measure our progress, and then we include the do part of the PDSA, which is carrying out the plan and documenting our progress. And then we do the S, the study, analyzing the data that we have then collected related to the do, and then act. What changes are still to be made, and should this improvement be expanded, for instance, organization-wide? So the small test of change is really important. It is the punchline of the PDSA process in terms of you then define an intervention, do it, and monitor it to see if it makes a difference. So how does this all work together? Because we've covered quite a lot of territory and detail in this territory. First, we've started with the Institute of Medicine aims, which is the safe, timely, effective, efficient, equitable, and patient-centered care. That leads to a framework of measurement, the structure, process, outcome, so that we can figure out a way of measuring the care that we're giving. Then we organize data related to the measurement, identify a problem, if there is a problem, do the root cause analysis, identifying the cause of the problem, and then doing the small test of change so that we address the problem, correct it, and improve patient care. We're now turning to the student learning experiences related to quality, and this is so critical in developing our future nurses to really have an impact, improve care. One student learning experience is to have each student identify a clinical problem on the unit that they're working in or the setting that they're working in. The problem could be identified either from data that's collected, their own personal observation, discussion with staff nurses, or comments and conversations that they've had with patients and family members. The problem needs to meet the criteria of being important to staff or patients, being measurable and fixable. You could then create groups of students, perhaps 4 to 5 students, and have them select one of the problems that the students have identified, and have the group do a root cause analysis and a PDSA on that problem. And then have each group report the exercise at the end of the clinical. They can either do a verbal report or they can do a written report. Another student learning experience that can be very helpful in getting students to learn about public reporting is have the student go to one of the Compare websites to look at information related to the clinical setting that they're going to be going into, whether it's a hospital or a nursing home or a home care agency. And then have the student, after looking at the Compare websites, have them do an analysis in a paper of what they found in the website as compared to what their experience was working and caring for the patients in the setting. And this would be a topic that would be, wonderful to talk about at a clinical conference, and discuss the complications and the importance of data with the students, because the interesting aspects of looking at public reporting is that it's not always clear how useful it is, how the public is interpreting it, and it's important for students to understand this about the data. It's also important for students to understand where the data comes from and how robust it really is. So this could be a wonderful way of creating a discussion at a post-clinical conference. Another learning experience for students is having them attend a quality improvement committee meeting. Every hospital and nursing facility is required to have a quality improvement committee. And the discussions in these committees are often very informative and can help students understand how data is reviewed and how it's used to improve care in a facility. So after a student has attended a quality improvement meeting, have them assess that meeting based on the importance of the care issues discussed, the data that was used to review the issues, the participation level of nurses on the committee, and the relevance to nursing care. And the student assessment can be a report or part of a discussion of any course that's in the nursing program. The final student learning experience that I'll talk about is to have the student identify data that's collected on the unit that they're providing care, the facility, or whatever setting they're in, and have them trace the flow of data in terms of who collects it, who sees the data, who's responsible for managing and then acting on the data. The student should also include an assessment of how the data is used on the unit to improve or to continue to monitor care. And this exercise can be either a written report, a discussion, or a presentation. But it is really important for students to understand the flow of data from collection to use to patient care improvement. In conclusion of this theory burst around quality improvement, I want to make some very important points. One is that the quality of care will not improve until nurses are fully engaged. I believe this in my heart of hearts, that nurses are the key to improving care. And until we are fully on board with measurement and integration of quality into the very fabric of nursing, that care won't change. And care cannot be improved unless it's measured. Measurement is how we know how well we're doing. As well-intentioned as we are as nurses and as good a job as we think we might be doing, we might be surprised to know exactly what we are doing if it's measured. So care cannot be improved unless it's measured. And it's our professional responsibility to improve care and keep patients safe. Nurses are the most trusted profession. We have been the most trusted profession for as long as the Gallup poll has been monitoring trust of professions. And we need to live up to that responsibility and keep our patients safe and give them the very best care possible. Thank you for listening to this Theory Burst.